Hello, my name is Brenna McGrath, and this is my submission for NURS-FPX 4010, Leading an Interprofessional Practice, Summer 2023, Section 66, Assessment 1, Collaboration and Leadership Reflection Video. As a registered nurse, collaboration, leadership, communication, cooperation, and advocacy are crucial to successful care and treatment and positive patient outcomes. Neglecting these components of the job can lead to an extension of hospital admissions, a waste of human and financial resources, mistakes that can physically harm a patient, and much more. This video will expand upon one of my personal experiences with interdisciplinary communication, how it could have been handled differently or better, and how the team ultimately achieved the desired outcome. Criteria 1. Reflect on an interdisciplinary collaboration, noting ways in which it was successful and unsuccessful in achieving desired outcomes. Last year, I was working as a registered nurse on a 16-bed inpatient oncology unit. We provided symptom management and emergency treatment for oncology patients. There were also times when our oncologists, who also have outpatient offices, would plan direct admissions for their patients if the patient needed an infusion, such as blood or chemotherapy, and the doctor expected medical complications of transfusion reactions due to experiences from past infusions. A direct admission is when the patient and their physician planned a date and time for the patient to be admitted to the oncology unit. The nurse manager and staff block a room from getting an ER admission. The direct admit patient has the privilege of bypassing the wait in the ER. They simply check in at central registration and get transported via wheelchair directly to the room blocked for them. There are several steps and levels of communication and interprofessional collaboration in order to make a direct admission smooth and successful, including the physician, nurse manager, nurses, supervisors, and bed planners. I am going to describe an instance when this kind of planned admission went wrong due to poor collaboration and leadership. To start, only 1 week before this event took place, the oncology nurse manager who was in charge of the unit for over 30 years resigned from her position and accepted a new job. Taking her place in the interim was the director of nursing. We will call her Amy for purposes of anonymity. Amy has a reputation around the hospital of being dismissive and absent on the floors. She is quick to criticize and apprehensive to congratulate. The staff on the oncology unit were much less than thrilled to have to report directly to Amy while the search was on for a new nurse manager. Another main character in this story was the patient. We will call her Rebecca for anonymity purposes. Rebecca was newly diagnosed with cancer and began the fight of her life by starting chemotherapy infusion treatments. For her first treatment, Rebecca presented to the outpatient infusion room. Very shortly after the chemotherapy infusion was started, Rebecca began to tremor, then shake vigorously, and had a presumed seizure. The chemotherapy infusion was immediately stopped, a rapid response was called, and she was admitted to the hospital for a severe chemotherapy reaction. Unfortunately, the chemo that Rebecca received was one of the best and only options to treat her cancer. Once she was well again, it was decided between Rebecca and her oncologist that she would try the treatment again, but not without extreme caution. Her oncologist planned for her to be directly admitted to the ICU, where she would need a 2-to-1 nurse-patient ratio for intense monitoring while the chemo was infusing, and immediate action could be taken if things went wrong again. Both an ICU nurse and a chemo-certified oncology nurse were to monitor Rebecca while she was getting the infusion. The oncologist communicated with the interim oncology nurse manager, Amy, and the ICU nurse manager, who spoke to the nursing supervisor and bed planner to solidify this plan to treat Rebecca. The ICU nurse manager relayed the plan to his nursing staff, but unfortunately, for whatever reason, Amy did not relay the plan details to the oncology nursing staff. The morning of Rebecca's direct admission to the ICU, the oncology unit nursing staff was thrilled to have adequate staffing. 4 nurses for a full unit of 16 patients. This was a very rare occasion. All 4 nurses received a report from the night shift in the morning and began to assess their patients and pass out morning medications. At about 9 a.m., the oncology nurses received a call from the ICU nurse stating he was taking care of Rebecca this morning and asking who was coming to begin her chemo infusion and when. The oncology staff was very confused, being completely left out of the loop of this plan. One oncology nurse called Amy to inquire about what the ICU nurse was talking about. Amy seemed flustered but insisted that Katie, one of the oncology staff nurses working that day, was not supposed to take a patient assignment that morning and was told to report off to the other oncology nurses and report to the ICU immediately. Criteria 2. Identify ways poor collaboration can result in inefficient management of human and financial resources, supported by evidence from the literature. Confused and frustrated, Katie, who was in the middle of a med pass, had to hand her patients off to the other 3 oncology nurses who were also in the middle of their morning med passes, leaving them short-staffed once again. Not only were the oncology and ICU nurses frustrated and angry, but Rebecca did not receive her chemo infusion until 2 p.m. when it was originally scheduled for 9 a.m. Since Katie was not aware of this responsibility, the chemo that was already mixed expired before she was able to check and administer it. According to Peterson, being available and being receptive must be present for collaboration to function. Being available refers to having access to the needed resources for collaboration, place, time, and knowledge. Place concerns the employees' access to each other. Another dimension is time. Initial time commitment refers to the beginning of a collaborative relationship where extra time is needed to plan, discuss, and create consensus about how to engage in collaboration. Investment in communication at this phase often saves time later because it prevents conflicts or misunderstandings between colleagues, and patients are less likely to get into crisis. Finally, knowledge concerns access to appropriate and relevant professional knowledge from colleagues about treatments and patients. The process of sharing is an important factor, and people are more likely to collaborate with colleagues who they perceive as having pertinent knowledge. Receptiveness refers to how the resources are being handled and made available between the employees and focuses on the attitude and willingness of the employees to use and offer these resources. The elements in receptivity are interest, discussion, respect, and trust. Criteria 3, identify best practice leadership strategies from the literature that would improve an interdisciplinary team's ability to achieve its goals. According to Gachet, perceived utilization of leadership styles among nurses, there are several leadership styles that a nurse leader or manager can practice. The leadership styles with the highest satisfaction ratings are transactional, laissez-faire, and transformational. The transactional leadership style motivates and directs followers to the leader using rewards and punishment. The laissez-faire leadership style is one in which there is little or no guidance from the leader, and the leader gives employees all authority and freedom to work independently. The transformational leadership style influences followers towards achieving more than what they have planned by using leaders' skills to influence followers towards achieving goals by changing followers' beliefs, values, and needs. The leadership style practiced by a nurse manager can greatly impact the staff nurse's satisfaction, motivation, and performance. Authoritative leadership styles such as totalitarian can be harmful to the overall morale of the team. Excessive punishment and minimal rewards or recognition can lessen a person's desire to perform at their best ability, which affects the overall patient experience and makes it difficult to retain nurses. Criteria 4. Identify best practice interdisciplinary collaboration strategies to help a team achieve its goals and work more effectively. According to Cow, trust crisis, new frontline nurse managers' ethical experience on their units. Trust crisis, tests on capability, and conflict are the main issues preventing a collaborative team to remain cohesive. All of these principles were challenged as soon as the disliked director of nursing took interim managerial responsibility on the oncology unit. The previous manager was personable, relatable, interactive, and involved with the oncology unit staff and patients, and it was very difficult for anyone to replace her. If the director of nursing was more available and more receptive, as mentioned above, perhaps the situation would have had a much less complicated outcome. Thank you for listening to my reflection video, and I hope you have learned how poor communication and collaboration between hospital staff can seriously affect direct patient care.